how to optimize this, and that's John Kanellopoulos. John, please.
Thanks so much. Congrats to Deep and Jad. Excellent meeting today. I think this is the first ISRS meeting I attended in full extent from morning till
wow.
I admit. I had taken breaks in the previous ones. Very excited to be here. We don't know about the ISRS future, but anyway, let's go to some fun stuff. How to use the experience of many years, and I'm going to try in 7 minutes and describe to you what I've learned over 20 years and over 80 peer-reviewed publications. And the question here is that we all know that any excimer laser today, any company, I do consult for Alcon, I want to make that clear, can give excellent results. So if our goal is 2020, let's wrap it up, let's go home, have a drink. If we're starting to view a laser refractive procedure as a procedure that can do more than help a patient get rid of their glasses or contact lenses, maybe improve the eye optics, this may sound interesting to you. How can we assess that? One of the objective poor measurements in my opinion is low contrastivity. And I'll walk you through our topography-guided experience to explain you how I, at least, have viewed this. This is one of my patients. As you can see up here, we're treating usual -6, this is the average in my practice, for myopic LASIK, with half a diopter astigmatism at 45 degrees. So the plus axis is somewhere here, 135, right? We all agree, though, that this regular astigmatism is not on that axis. And we would all agree that in 99.99% of patients, the actual refractive astigmatism of the eye is the corneal astigmatism. So what's going on here? The secret here is angle kappa. This is a regular astigmat, but this astigmatism, this corneal astigmatism, is not lined up on the line of sight. There is a slight deviation. This makes the cornea, with its astigmatism, act as a prism. And we're seeing here the attempt by the topographic guided ablation to correct this vertical coma, normalize the cornea. So if I'm going to use this ablation, I will have to rethink whether I'm going to use the manifest refraction of the patient or the topographic amount of astigmatism. If I do a wavefront optimized ablation, forget about all this, because the error will transfer onto what the patient will see afterwards. If I'm going to do a topographic guided ablation, I need to consider this. This is why some surprises with topographic ablations. How did we learn this? It was here in this meeting in 2004. Many of you were probably in training at the time, that we spoke of topographic guided ablations, of wavefront guided ablations with this particular platform. And it was through irregular eyes that we learned that all these entities mainly correct cornea aberrations. Another example here. This relatively regular cornea, you can see here again, the axis and the amount of astigmatism are way off as far as what the topographer is measuring and what the patient is giving in manifest. And this is where we came out in doing all this complex calculation called TMR. We named it topography modified refraction. When we do topography guided treatments in virgin eyes, and since we're normalizing the cornea to the cornea vertex, we need to take into account the actual topographic amount of axis and astigmatism. And in this study, under publication currently, we show that even going 50% the difference in axis and amount of astigmatism helps patients gain lines of vision. So this is how we come to ray tracing. Ray tracing is, for me, an accomplishment in showing that all this work has some foundation. It is a very complex technology. It was developed through about 15 years now. Manual data were published by Cummings and Nochen in 2008. And it was an automated algorithm by this device that can simultaneously take actual length measurements, it's an interferometer, sine fluid tomography measurements, sort of a Pentacam HR, and Hartmann-Shack wavefront. So the pioneer thing here is that the interferometry data are used to create an avatar 3D model eye for each eye evaluated. And then the sine fluid data used to track 2,000 rays towards the lens of the eye, and then the wavefront data to retrotract 2,000 rays from the retina to the lens, anterior surface of the eye. And the last step here is it also calculates tilt between the lenticular system within the eye and the cornea system. So these are examples of how this device can measure low and high order aberrations. It's very reproducible. Of course, the key here is that we always have to measure these in naive corneas, and we have to make sure the cornea epithelium is naive, and thus these measurements have merit. And this is an example of what the topography, it's not a topography here, slipped my tongue, the ray tracing is going to do on a zero refraction. It's going to improve the ocular optics to the line of sight. Sort of what we did all these years with topography-guided ablations, but in an automated way. This is done in seconds. Another example, look what the topo-guided would look like in this patient. Here, the ray tracing would also calculate tilt between the lenticular system of the eye, the crystalline lens, and the lenticular system of the cornea, and thus improve the cornea optics. What's the benefit? We've published on this. Gain in line of vision, and what's really impressive, better contrastivity post-op than pre-op. We have never been able, at least not in my hands in the past, to have better LASIK eyes post-op than we did pre-op. This is in our study using the NEI subjective feedback by the patients, and in all these basic everyday functions, we can see that the ray tracing eyes did outperform. And of course, I couldn't finish the talk without talking about keratoconus. We use this technology in keratoconic eyes, mild keratoconic eyes as well. And the big difference here is the fact that this technology views a keratoconic cornea as a tilted cornea, where the topographic guided normalization, we heard about this today, just normalizes the cornea as a single entity. Thus, as you can see here on the top, topography guided treats more in the cornea area, where ray tracing treats very little in the cornea area because it views that cornea as a tilted cornea. The advantage is less tissue ablation in the cornea. So in summary, we're reporting to you, and this is under FDA trial currently in the US, it's been CE marked in Europe since 2019, a new way to customize ablations. It's relatively objective, very little surgeon implication in this. It has its own way to validate the data, and key elements, improved visual function through improving the ocular optics of the eye, mainly through cornea aberrations, but whole eye aberrations as well. And thanks so much for your attention.
Yeah, we heard fantastic talks about innovation. Let's talk and discuss on